Hello, my name is Rachelle Pasteris, and I am an adult community mental health therapist as well as an advanced standing MSW candidate. I am pleased to present my project to you, which is known as Partnerships Through Voice. In my current practicum placement as a medical social worker, I have encountered many adults with substance use disorders. I've even witnessed firsthand the devastating toll of withdrawal symptoms and how they take their form on the human body, while individuals endorse feelings of guilt and shame. During my rotational experiences within the hospital mother and baby unit, as well as the multi-care behavioral health substance use disorder treatment program, I became very drawn to pregnant women addicted to substance use, as they've also expressed these same feelings along with fears of social and legal consequences, as many of their infants have a higher probability with being born addicted to substances. As a mother of two healthy children, I personally cannot imagine my life being intertwined with the legal and child welfare systems, like the pregnant and parenting women I provided medical social work services to. For the purposes of this paper, the term pregnant women will refer to anyone who is pregnant regardless of their gender identity. In my current agency, although this mostly includes cisgender women, substance use disorders have ravaged our society as they have affected millions of individuals across the nation and globe respectively. What is important to understand is that substance use disorder diagnoses include addiction, which is a medical disorder that affects the brain and changes behavior. Individuals are treated like second-class citizens when their undesirable behaviors related to substance use impact society negatively. This disdain is at a greater magnitude for pregnant women using substances, as their addiction directly impacts their fetus, other children, and families altogether. Research indicates that substance use disorders affect women across all racial and ethnic groups, all socioeconomic groups, as well as populations residing in rural, urban, and suburban communities. Washington State at the current moment considers substance use during pregnancy to be child abuse under civil child welfare statutes. However, a fetus is not considered a child until after they're born. As the law stands, it is notably counterintuitive when considering the human rights of the mother and baby as a unit. The law further stigmatizes pregnant individuals while providing no solutions for harm reduction and recovery of the individual and family. I spoke with a former child welfare practitioner who highlighted barriers to assess what is happening to a fetus in utero. In quotes, they stated, "We cannot have eyes on a child in order to assess what is happening to them," end quote. Moreover, the voices of the women most impacted by legislation are not included in decision-making process when considering their complex biopsychosocial and ecological needs that inform upstream, midstream, and downstream interventions for recovery. Providers such as physicians and nurses need trauma-informed and compassionate approaches while working with and providing treatment to pregnant women addicted to substance use, enhance their healthcare and recovery outcomes. The intervention that I'm proposing draws upon elements from trauma-informed care and the feminist theoretical framework within a non-judgmental and patient-centered medical clinic setting. Social workers are uniquely positioned to facilitate partnered and equitable collaborative exchanges during the decision-making process between women service users and providers by giving voice to those most impacted while considering them as a whole in all aspects of their life. To achieve this, social workers will conduct an orientation before the service user's first appointment with the provider. Orientation and care coordination will include universal screenings for substance use and self-administered screenings for depression and anxiety. Will also identify cultural norms, conduct biopsychosocial assessments, liaison and refer to ancillary community providers and resources, provide psychoeducation, initiate collaborative medical treatment plans, as well as obtain written consent to administer trauma-informed interview surveys. Social workers will facilitate interview surveys, with service users based on the 6 guiding principles of trauma-informed approaches. Additionally, survey interview questions will be translated from English to other spoken languages without losing the meaning of the questions asked. Responses written in another language will be required to be translated to English to assist social workers with meeting a service user's cultural and gender considerations. An example of a survey question would include the following. Within the shared decision-making process, how were you included and supported? In turn, consistent feedback from service user interviews will be collected during 3 different points of a service user's enrollment period for care services. These points will include during the orientation before the first provider appointment, directly after the first provider appointment, and once a month until the service user is discharged from care services. This is going to allow the voices of those utilizing services to be integrated into effective healthcare recovery outcomes, as social workers will share and debrief providers and other multidisciplinary professionals during weekly staff meetings. Additionally, service users will also be invited to join monthly rotational staff meetings in person to express their thoughts and feelings about their prenatal and addiction care, as well as be able to share and discuss what is helpful and what is not. They'll also be able to discuss anything that they would like to see differently and share other things that they would want to be included for improving care services overall. Service users will be reminded that their feedback cannot be used adversely, as it will to adversely impact their use of services, as they're protected under patient-centered care policies. Provider feedback will also be collected through reviewing case notes and meeting minutes to gauge their understanding between the correlation of trauma histories and substance using behaviors. My overall goal in the next few years is to have providers increase their compassion by integrating trauma-informed approaches through gender-informed and culturally responsive healthcare initiatives to promote positive recovery treatment outcomes for pregnant women addicted to substance use. Lastly, but not least, I would like to thank Dr. AB, Dr. San Nicholas, Professor Drake, Tanya Ruckenbrod, David Kraut, as well as my community mentor, stakeholders, and fellow cohort members for their contributions regarding this social problem and population.